Welcome to this explainer. Look, if you're a radiation oncology resident, managing metastatic spinal disease is basically your bread and butter. Systemic therapies are getting there, patients are living longer, and nailing durable local control in the spine is absolutely critical right now. So today, we're diving into a really fascinating 2022 retrospective cohort study from Ohio State. And this paper, it totally challenges the traditional limits of spine stereotactic body radiotherapy, or SBRT.
Okay, be honest. Would you prescribe SBRT for a 4-level contiguous spine metastasis? Yeah, that thought probably makes your heart rate jump just a little bit, right? But that's exactly the provocative clinical question we're tackling today. We're going to address that gut-level hesitation we all have when extending high-dose, ablative targets across multiple vertebral segments. The old dogma says keep SBRT to 1 or 2 levels tops, but is that fear actually backed up by the modern data? Well, let's find out.
Here's our roadmap for today. We'll hit the multi-level SBRT dilemma, evaluate the patient cohort, look at feasibility, dosimetry and setup, check out the local control outcomes, review the toxicity and safety profile, and wrap up with some solid clinical takeaways.
Section 1. The Multilevel SBRT Dilemma. So what is the core problem planners and attendings face with extensive metastatic spinal disease? It's the classic showdown, conventional external beam radiation therapy versus spine SBRT. We know SBRT is amazing for local control in 1 to 2 levels because of that high biologically effective dose, the BED. But the fear of setup errors has basically made conventional EBRT the safe, default choice for treating 3 or more contiguous levels. The big worry here is that tiny setup errors, especially those tricky rotational ones, get magnified over longer segments. And that magnification could mean missing the tumor or, terrifyingly, dumping way too much dose into the spinal cord and causing radiation-induced myelopathy. So the real question is, can our modern techniques actually overcome that hurdle?
Section 2. Evaluating the patient cohort.
To really test this long-standing dogma, researchers looked back at 194 SBRT courses from 2013 to 2019. And the contrast between the two groups they studied is wild. Group A had patients treated at 1 to 2 levels, while Group B included patients treated at 3 to 7 contiguous levels. The data shows the 3 to 7 level group was inherently so much more complex. We're talking massive targets, a median PTV of 150 cc compared to just 52 cc. Plus, a whopping 61% of them needed surgical intervention compared to 21% in the other group, and way more of them had progressive systemic disease. As residents, you've got to realize these multi-level patients aren't just larger treatment volumes. They are fundamentally sicker, more heavily pretreated, and geometrically much more complicated.
Section 3. Feasibility, dosimetry, and setup. Okay, so how on earth do you safely deliver ablative doses to a 150 cc target that is literally hugging the spinal cord across multiple levels? Well, the secret sauce is an incredibly rigorous setup protocol. First, you need rigid, full-body immobilization, like a thermoplastic frameless mask for the cervical spine or a stereotactic body frame and vac-lock bag lower down. Second, and this is absolutely crucial, they used a 0 mm PTV expansion, 0, alongside a tight 2 mm planning risk volume, or PRV, around the cord and cauda equina. And step 3 is where modern tech really saves the day, relying heavily on a 6 degree of freedom couch paired with daily cone beam CT. That exact combo is what neutralizes those terrifying rotational errors.
But did this actually translate to good plans? Absolutely. Dosimetrically, it was highly feasible. The planners got fantastic target coverage. Getting at least 95% of the prescription dose to 95% of the PTV was statistically similar between the small and large target groups, 96% versus 89%. And the median max spinal cord DED, totally comparable, sitting safely at 57 gray for the multi-level group versus 46 gray. Even crazier, in the 10 insanely complex cases covering 4 to 7 contiguous levels, 70% of those plans hit ideal coverage goals without blowing past any organ at risk constraints.
Section 4. Local control outcomes.
Now for the million-dollar question. Did this technically demanding treatment actually stop the cancer? When we evaluate the cumulative incidence of local failure, the results are honestly striking. The 1-year rate of local failure was 11% for 1 to 2 levels and 16% for 3 or more levels. That's a p-value of 0.747, meaning the difference is statistically negligible. This proves that despite those massive volumes and all that geometric complexity, local failure is practically identical no matter how many levels you treat with SBRT.
Section 5. Toxicity and safety profile.
Look, as an oncologist, you know efficacy means nothing if the morbidity is catastrophic. We have to talk about radiation-induced myelopathy. The incidence rate in this study? 0. Not a single instance in this entire cohort of complex multi-level treatments. No myelopathy, no radiculopathy, no plexopathy. Actually, scratch that, there were absolutely 0 grade 3 or higher toxicities, period. Acute or late. The acute stuff was strictly limited to mild grade 1 or 2 fatigue, some dermatitis, nausea, and minor pain flares.
Another massive fear with spine SBRT is structural failure, right? Vertebral compression fractures. Well, the data shows that the risk of a new or progressive fracture was statistically identical, regardless of the number of contiguous levels treated. It was an 8% fracture rate for 1 to 2 levels and just 9.5% for 3 to 7 levels. That is well within the historical acceptable limits of around 15% that we usually cite for spine SBRT.
Section 6. Clinical takeaways. So what does this actually mean for you in the contouring room? Let's distill this into something practical. They ran a multivariate analysis to find out what actually predicted local failure in the 3+ level group. Male gender popped up with a hazard ratio of 2.7, but the authors noted that might just be statistical noise. The real elephant in the room? Uncontrolled systemic disease, coming in with a massive hazard ratio of 4.15. This is a huge neon sign flashing patient selection. Poor systemic control means you're dealing with a far more treatment-resistant disease overall.
Here are your core, practical takeaways to bring to the clinic. Number 1. Multi-level SBRT is geometrically feasible and dosimetrically safe. You can do it. Number 2. Reserve this intense therapy for well-performing patients who have excellent systemic options and controlled systemic disease. Number 3. Stringent image-guided radiotherapy is non-negotiable. You absolutely need that 60OF couch and daily CBCT. And number 4, 0mm PTV expansions totally work, but only if your institutional setup and daily reproducibility are absolutely flawless.
Ultimately, the authors of the study concluded this. For patients with 3 or more contiguous involved levels, spine SBRT is feasible and may offer excellent local control without significant toxicity. The old-school reluctance to treat extended spine segments with SBRT out of fear of setup errors or cord toxicity, it just isn't justified by the modern data anymore, assuming you have the right tech and protocols in place.
So, I want to leave you with this final thought. As you continue your radiation oncology residency, as you master your contouring, and as systemic therapies keep extending patient survival, ask yourself, is it time to leave the old dogma behind? Is it time to make multi-level spine SBRT your new standard of care? Thanks for tuning into this explainer. Keep asking the hard questions, and I'll catch you next time.